Yeah. Hello, friends. So I'll be talking on this subject, hepatorenal syndrome. So I believe this has been asked as a question for DRNB. So I wish to acknowledge my colleague, Dr. Diksha, who helped me develop this content. Friends, hepatorenal syndrome is a quite a common condition. I'm sure most of you would be seeing in your clinical practice. But I'll just focus on what are the key updates on this. So I'm sure you would have heard a lot on this hepatorenal syndrome, which is a diagnosis of exclusion in someone with cirrhosis of liver. But we'll talk on what is the key updates that as an intensivist when you're treating, one has to know. Uh, so as the name sounds, when you say hepatorenal syndrome, obviously one needs to have an underlying cirrhosis of liver with portal hypertension with an acute kidney injury. So the predominant reason for this is there is a sort of a renal vasoconstriction that tends to happen, which leads to functional acute kidney injury. So which means structurally there is no problem with glomeruli or tubules, although the recent evidence suggests there could be having an overlap of acute tubular necrosis also, but functionally, AKI sets in because of the cirrhosis of liver or the liver failure with portal hypertension leading to the acute kidney injury. And this may have associated hypoxemia also that may be prevailing, which is a separate entity, predominantly called as hepatopulmonary syndrome. I've given a separate video on that, so you can go and refer to that. But it can be present concurrent with hepatorenal syndrome also. So there are certain risk factors as to which are the patients who develop hepatorenal syndrome. Someone with advanced cirrhosis of liver with a high MELD score or high child-pugh score, which basically tells you that the cirrhosis or the underlying liver disease should have progressed to the higher stage, higher MELD, higher child-pugh score, or someone who comes in shock, or someone who has a variceal bleed. So someone with portal hypertension coming with a variceal bleed, these are act as a trigger and risk. Or someone who's having sepsis with worsening hypertension or shock could be a trigger for worsening acute kidney injury, which we all understand intuitively that these are all the risks. But when I show you the criteria, actually they all become excluding factors, which we'll talk about. So these are the risk factors. So before we used to call as HRS1 and HRS2. So for all intensive care trainees, be aware of this new nomenclaturing. Now the classification of HRS is HRS AKI and HRS CKD. So very simple. Before it used to be called HRS 1 and 2. Now we call it as HRS AKI or HRS CKD. And now the current understanding is the AKI based sort of a criteria that we use to stage AKI, like KDIGO criteria, is applicable to HRS. So these are certain newer developments that have happened in this. So now you can apply this KDIGO criteria and use that as a tool to stratify the severity of acute kidney injury even in HRS. So now looking into, I'm sure during my medicine post-graduation days, so what is the pathophysiology of hepatorenal syndrome or hepatopulmonary syndrome? The traditional hypothesis, which again has changed, the traditionally what we knew was there is a vasodilatation. There is a systemic vasodilatation that happens in cirrhosis of liver, and there is a splanchnic pooling that happens in cirrhosis of liver. Then there is effective circulating blood volume, which comes down. These were considered as the key elements that would lead to hepatorenal syndrome. So this was our earlier understanding. Effective circulating blood volume is low. Splanchnic pooling happens because of the portal hypertension, and there is a systemic vasodilation. This leads to organ dysfunction. So this was our understanding. Currently, the new hypothesis is, as I said, there is more of renal vasoconstriction that tends to happen, and the emphasis has shifted to immune dysfunction that tends to happen in cirrhosis of liver with portal hypertension, which acts as a trigger for acute kidney injury. And this portal hypertension leads to certain peptide changes, which can also contribute to this acute kidney injury. And the new HRS pathophysiology puts emphasis on there can be HRS along with other acute tubular necrosis also, which can coexist. So this acute tubular necrosis also, which may be adding on as a risk, as a component for acute kidney injury that sets in hepatorenal syndrome. And this is a new thing. The most newer thing is there is a gut dysbiosis that happens And this also, there is a microbiome changes that tends to happen because of the portal hypertension. The gut integrity is lost, and there is a gut translocation. And there is a separate video I have done on gut microbiome and dysbiosis that happens, which leads to smoldering sort of an inflammatory process, which leads to AKI. So this is a new sort of an understanding that gut microbiome and dysbiosis has a role, and urea itself acts as an inflammatory sort of an agent, which leads to chronic in low grade inflammatory state, which leads to AKI. So this is the new evidence or the new pathophysiological basis for AKI in hepatorenal syndrome. So simplistically thinking, gut dysbiosis, you have to mention renal vasoconstriction, immune dysfunction, peptide changes, and urea as an inflammatory marker leading to AKI is the current understanding, as opposed to systemic vasodilation, splanchnic pulling, and effective reduction in circulatory blood volume. These are the changes that have happened. So now, what is the updated diagnostic approach? This is important for all our intensivists. What is the diagnostic? Because this is very quintessential for every intensive care trainee to know, especially we are dealing with acute kidney injury in cirrhosis. So there is a five-step approach. This is important. Please focus on this and keep this in your mind. There's a five-step approach, how you approach a case of AKI in renal. So first thing is to exclude the evident causes of AKI, which could be drug induced, or which could be hypovolemia, or which could be sepsis. So you have to rule out the other possible causes of AKI, which traditionally we knew when we had to label someone as HRS, there should not be a known cause of acute kidney injury. There should not be nephrotoxic drugs, there should not be hypotension, there should not be underlying sepsis, or there should not be any structural problem in the kidneys, so on and so forth. So you have to exclude other causes. So, like as I mentioned, drugs, hypovolemia, and sepsis. After that, once you have excluded, you believe it is hepatorenal syndrome. So one has to administer albumin, 1 gram per kg, up to 100 grams. You have to give an albumin challenge. After albumin challenge, one needs to see if there is going to be change in the serum creatinine. So if serum creatinine is say high or 2 or 2.5, there has to be a trend towards getting better in 48 to 72 hours. Serial creatinine monitoring has to be done after the albumin challenge and see if it improves. And then there is an emphasis on using biomarker assessment using NGAL as a tool to identify as a renal biomarker etiologically whether NGAL is high. So we take NGAL of more than 130 as a reference value to see if this is high, and you have to use this as an adjunct. And there is an emphasis on doing a renal ultrasound and the focus ultrasound to see whether there are any structural problems in the kidney, and to do the lung ultrasound to see if there is a congestion of fluid or B lines secondary to shift of the fluid. And early diagnosis will help in reversal of acute kidney injury, especially not allowing the creatinine to go more than 2.5 portends a good prognosis. So this is a simple diagnostic approach in following the HRS. So the simplest rule the other causes, give albumin, and when you give albumin, your expectation is serum creatinine should start improving, and you can use biomarker assay, do an ultrasound, and try to, and the reversal of acute kidney injury, the evidence indicates is much better if creatinine is less than 2.5 and not allowed to go more than. After 2.5, it is hard to reverse with this albumin and terlipressin. We'll talk about it. So this is the five-step approach. So now, what is the treatment? So what is the evidence? The 2024 evidence on the first line treatment. Once you have labeled as HRS, the treatment of choice is albumin along with terlipressin, which I'm sure most of you. So what is the albumin dose? 1 gram per kg. If it's a 60 kg individual, give 60 grams. Maximum up to 100 grams per day, you can give this albumin. Terlipressin dosage is 1 to 2 milligrams, 6 hourly. So is there evidence? Is there an evidence this is going to help in reverse of HRS? That comes from this study called CONFIRM trial. So this is a landmark trial which came in NEJM, which I'll talk about, which clearly indicated that this combination of albumin and terlipressin showed good reversal of hepatorenal syndrome. 40 to 50% reversal rates are possible with this sort of combination, but the quintessence is to identify early and start treatment early to have better outcomes. So let us look into this trial. So this particular trial came in 2021 by the US group. So they had 300 patients, 199 in terlipressin group 101 in placebo. So hepatorenal syndrome reversal happened in 32% as compared to 17%. And as you see, it was statistical. So it was this combination led to a good reversal of HRS, and it had an ability to reduce the creatinine less than 1.5 in 14 days, in 39% in terlipressin and 18%. And as you see, it was statistically significant. And day 30, need for renal replacement therapy also. So the patients who did not need RRT was more in terlipressin group as compared to the placebo. And they did a subgroup analysis about whether HRS reversal in SIRS also happened better in terlipressin group as compared to the placebo. So which means it was a very strikingly positive study that terlipressin showed favorable benefit in HRS reversal in all subgroups. And they even looked at day 90 liver transplant, and that did not show any major difference between terlipressin. But what the disadvantage in terlipressin was, terlipressin group had more side effects. They had abdominal pain, vomiting, diarrhea, so on and so forth. The side effects were more. So there was increased adverse effects in the terlipressin. So the recommendation for the treatment of albumin and terlipressin comes from this confirmed trial, and subsequently multiple other smaller studies came, which also showed signals towards better outcome and reversal with terlipressin. So now, what is the first line treatment? As we mentioned, the key findings is the sooner you start, better is the outcome. So there is higher reversal rate that was shown, especially if you start the treatment early. When is it early? Not allowing creatinine to go more than 2.5. The reversal rates were much better. And it was found to be cost effective if the treatment is started early. And try to use NGAL more. I think in India, we're not using it very much. Maybe we should start doing more of urinary NGAL as a biomarker to predict non-response. Because if NGAL is high, it means there is some problem in the kidney, and the HRS may not show the response that you would have loved to see. So it basically predicts non-response. And always, as you saw the algorithm 5-step, do a ultrasound to look for structural changes, and also look for B lines to look at the fluid shapes, especially when you give albumin and terlipressin. And it is imperative there is a monitoring of daily creat, daily urine output, respiratory status, because when you give albumin every day, up to 60 grams per day, along with terlipressin, there are fluid shifts and patients can go into pulmonary edema. We see that. So it is important. So there is a focus, which is important for intensivists. Do your ultrasound, follow the B lines. If there are B lines, you may have to use diuresis, assess respiratory status, because very often we get patients are given albumin in the ward, they come with respiratory distress to ICU. How often you would have seen, friends? I'm sure all of you who are listening to this would have seen that gastroenterologists give albumin, they become short of breath, they come to ICU, we would put them on NIV, we would diurese them, so on. So this is important that you pick them up early. Don't allow them to decompensate, and look for the response. Once you start albumin with terlipressin, the response should start appearing in 48 to 70 hours are the key thing. So now let's look into emerging therapies in hepatorenal. So there are new therapies, because I'm only talking about an update. What is it an intensivist needs to know? What are the emerging therapies? So TIPS. TIPS is an important tool. Once someone has gone into HRS, so one has to contemplate the role or the usefulness of or the value of TIPS. And there is an ongoing trial from the German group called Liver Hero trial, where they're looking at TIPS as a tool or as a standard of care for someone who has developed HRS. And there is a focus on long-term albumin usage as prophylaxis for not getting these patients to get into HRS. So there is a sort of a research in this area on long-term albumin usage to prevent patients going into HRS. And this is interesting, I found. This is available in the market called Alpha Pump. Maybe in India, we should think of using this. I have not used this. Alpha Pump, where you have a peritoneally kept a pump which tends to draw the ascites fluid and redirects it into the urinary bladder, so that there is a continuous sort of a drainage of the ascitic fluid through the urinary tract, which is Alpha Pump. So this is something one should look at from the intensive care, rather than repeated ascitic tapping that we do externally, which puts them at a risk for infection. This is an internal process where ascites is drawn with the pump and redirected to the urinary bladder. And use of AARC NGAL score. So this is an important score, AARC score. I will show you what are the components of AARC score. AARC score is to try to have a criteria based sort of a diagnosis of hepatorenal syndrome. And using this as a criteria along with NGAL goes a long way in helping you to confirm the diagnosis of HRS and rule out any other structural problems. I think we should start using more NGAL in our practice so that we have some delineation whether it's HRS or more of kidney related AKI. And there is a renewed emphasis on altering this gut dysbiosis with fecal microbiota transplantation and preventing this gut dysbiosis and maintaining the gut microbiome. There is a renewed emphasis on this. And there is a emphasis on stem cell transplant or regenerative medicine to regenerate the dead liver or the cirrhotic liver and extracorporeal liver support. So these are all the emerging therapies in cirrhosis and hepatorenal syndrome. So now what's new in 2024-25? I think for all trainees, you are keen to know what is it. So basically for HRS and AKI staging is based on KDIGO staging itself. You can use the conventional criteria that you use for AKI staging. And if the NGAL is more than 150 nanograms per ml, it will basically tell there is an underlying structural problem in the kidney and there is a concomitant presence of acute tubular necrosis along with functional AKI. So NGAL is important. We should start doing this more and use focus ultrasound to determine whether there is an obstructive cause for AKI and look into the lungs, whether there are B lines and try to modulate your fluid sort of a shifts with albumin and terlipressin. And always the key is early diagnosis of AKI. When I say early, try not to allow the creatinine to creep more than 2.5. Once it goes more than 2.5, the studies have shown reversal of AKI in HRS becomes very difficult. And prognostic factors, you can look at ACLF grade, which are conventionally used for acute or chronic liver failure to predict the response. And as I said, serum creatinine less than 2.5 milligram per deciliter has shown to have better outcome. And you can do AARC HRS score to confirm the diagnosis of HRS for risk stratification, which I'll show you the criteria for that. It's a new score. I think all trainees, it's good that you talk about AARC score when this is asked in exam. It's a very simple sort of there are 6 dimensions to AARC score, which I'll talk about. You can, and it's easy to remember. And key element is to avoid delays. Every day delay in identifying HRS and treating it appropriately has shown reduction in the reversal chance. And once they've gone into HRS, one should be listing these patients for possible liver transplant because many of them eventually go on. If after TIPS, the next step that they would go for definitive sort of a management would be early liver transplant in this. So what are the components of AARC HRS score? As I said, it has 6 components. One is it takes into ACLF score. The patient should have acute or chronic liver failure. So one should have that to call it as AARC, to call it as a HRS. And there should be increase in serum creatinine by more than 50%, or there should be isolated creatinine value more than 1.5 milligram per deciliter to fulfill the criteria for HRS. There should be a jump of more than 50% or creatinine more than 1.5. And you call it as AARC HRS, especially when albumin, after giving albumin, when there is no improvement, then you would say it is getting into established HRS. There should be absence of shock and there should not be nephrotoxic drugs and there should not be underlying renal tubular necrosis or acute tubular necrosis. So these are some of the criteria that has been put in place for AARC HRS criteria. But having said this, the first slide I told you that now HRS understanding is HRS can be present along with underlying ATN. That's why there is a renewed emphasis on using NGAL to identify whether there is a concomitant presence of ATN also, which may be contributing to the AKI. But this is some criteria that you can use it as a AARC HRS as a risk stratification and prognostication. So coming to the last bit, what are the future directions that are happening in HRS? So the future direction in research is precision medicine. And as I said, long-term usage of albumin as a prophylaxis to prevent patients into going HRS is an evolving area of interest. And there is a protocols being developed where terlipressin could be used along with norepinephrine. So terlipressin with norepinephrine based sort of a protocols are being evolved and using AI as a predictive model to predict the type of chronic liver disease patients or ACLF patients who may go into HRS is an area of research. And newer innovations in the extracorporeal liver support like DP Mars or plasma exchange that conventionally we are using So double filtration, DP Mars, and all these liver support devices is something that is getting renewed interest. And regenerative medicine. So in fact, our hospital, we are part of a study with Indian Institute of Science where they have used the cell lines of the liver for clearance of liver toxins by extracorporeal circulation. So this is a part of the study. So regenerative medicine is out there, and there are these regenerative cells that are developed which can purify the liver toxins. So this is a new area of interest, and the whole emphasis is on altering the gut microbiome, preventing dysbiosis, and modulation of the gut microbiome is the way things are evolving. So this is the update, most recent update that I can sort of give an overview on hepatorenal syndrome, friends. So it is an exam topic for all DRNBs. I think if you write all these components which I have elucidated, I think you will be good. And this is the latest that we have on HRS. So thank you, friends. So request you all to submit your work to Journal of Acute Care. And of course, you can visit my website to rehear to my lecture. Thank you. Thank you, and all.